Well, thank you all for joining us for the second progeny panel. The first panel was on LGBT benefits, employee benefits, and this panel is going to focus more on the transgender community. So why don't we first go with the introductions, and I can dive into our questions.
Sure. I'm Mark Leondires, Dr. Mark Leondires. I'm from Illume Fertility, so I'm a reproductive endocrinologist, which basically means I went to school forever. So I'm the medical director of an IVF clinic. I'm also the founding partner of Gays with Kids. I'm also the founder of Gay Parents to Be. And at this point in time, my practice is about 70% LGBTQ plus. We're one of the few fertility practices in the country that's 100 score on the HRC Health Equality Index. And so in my daily work every day, I'm speaking to our community about how to build a family. Personally passionate about it. I am a member of the community. I have donor-conceived children, and I talk about this from the heart. And so I'm here to help out as much as possible, get people started, and answer any questions.
Awesome. And my name is Lissa Kline. I am Senior Vice President of Member and Provider Services at Progeny, which is a fertility benefits company, women's health benefits company. We offer the fertility benefit and have a network of providers, of which Dr. Leondires is one. So I've been with Progeny for over 6 years, actually just about 6 years. Prior to that, worked here in New York City at Columbia University Medical Center at their reproductive endocrinology clinic, so their IVF clinic. And one of my many jobs there was running the donor program. So worked with recipients and donors, intended parents, and so have a good understanding of sort of the general process. Really excited to be here.
So diving in, for the LGBTQ plus community, can you give us a kind of a snapshot of the various pathways towards parenthood that are currently available? I mean, in the prior committee, you talked about what's available now, what may happen after the election. So what do you talk about what's currently available to that community?
Well, I think as anybody who's a member of the community, we have to realize that it's pretty unlikely you're going to have an accidental pregnancy unless you're a member of the trans community and your partner, and you kind of can do that on your own. So I talk about pathways to parenthood being, biological, adoption, or foster to adopt. Those are the three basic pathways. So if you want to pursue, biological parenting, and we'll use this vernacular for right now, if you're in a same-sex cisgender female couple, then you're going to need a sperm source, and one of you is going to likely choose to be pregnant, right? If you're in a same-sex cisgender male couple, then you're going to need an egg donor and a surrogate in order to have a biological child. Now, both of those combinations can move forward with adoption as well, although that's hard in our current United States as well. And then, if you're a trans couple, and that's part of where we're kind of going to talk about today, you have to kind of really take apart the pieces and understand that really, use of gender-affirming hormone therapy, thinking about fertility preservation, all those things that you can do proactively or post-treatment are things that can move you towards biological parenting. So most of my career is spent on biological parenting. I'm very familiar with adoption and foster parenthood, but it's not what I talk about every day.
And there has been an increase, and what do you attribute it to, the increase in LGBTQ parents, seeking more care and seeking more options?
Yeah, so I think that our community has felt more safe after 2015, marriage equality, and you can actually look at the numbers of people gay male couples choosing to build families through surrogates. There's a big kind of jump after 2015. The other part of the story is that, with some of the cultural changes, there's more access to care. So we live in this bubble where there's access to care for LGBTQ plus people, but that hasn't been the case everywhere, but that is becoming more and more. And then, access to care from, having good sources of donor sperm, and to have a really clear pathway to pursue donated eggs and gametes. So I think it's a combination of safety and knowledge. So in 2019, Family Equality Council completed a survey, and it said that there were 3.4 million LGBTQ plus identified millennials that wanted to think about family building. And it was, if you compared that to people identified as straight, it was 54% versus 48%. So there's a lot of young people, younger than me, who feel comfortable. And one of the things that buoys me on a regular basis, I see 30-something couples that want to have their baby, and I use this term carefully because we just talked about it. They want to have a traditional pathway, and that they're going to get married and have kids, right? And for me, in almost 60, like that's something that was unheard of when I was in my 30s. Like it didn't even really exist, right? Barely. The first child born from egg donation surrogacy for a same-sex cisgender male couple was in the early 2000s. So it's not that old.
So this is not part of our set questions, but I like to, dice you up. The bubble may burst November 2024. And do you feel the genie's out of the bottle and we'll continue to see the rise in that care for families? Or do you think that should a new administration come in and with the Supreme Court the way it is currently, that they'll really tampen down and the numbers will go in the opposite direction? If you had a crystal ball.
I think the genie's out of the bottle in the Northeast.
It always is.
Yeah. So, I had this discussion with my husband who was looking to move, and I said, well, I don't think the tanks are going to come down Connecticut, tell us we can't be who we are. But I think it is concerning if you live in the different parts of the country for what you're going to be able to do, and that might move people to move as well, because I think the genie's out of the bottle for family building for the LGBT plus community. And just because you're a member of the community doesn't mean you don't want to be a parent. What are your thoughts?
Yeah, I think
from a corporate perspective as well.
Agree with you. I also think that all of the paths to parenthood that you've talked about also apply to heterosexual and single people. And so I think maybe because of that, there's some protection there, right? IVF, surrogacy, egg donation are paths to parenthood for everyone, regardless of your sexual orientation or gender identity. And so I think in that way, the genie's probably out of the bottle.
Okay.
Yeah.
So in your practice, have you seen an increase in patients seeking care? And is that because of things the employers have done or because of society? What would you say as far as your practice and how that has changed?
So at Progeny, speaking from the benefits perspective, I joined Progeny, I said, about 6 years ago, and at the time we were covering 1 million lives. 1 million people in the US had access to the benefit. As you look towards 2024, we're covering 6 million, 6.7, I think, something 6 point something million people. And so access, just looking at Progeny, which is I think 12-ish of managed care in the US for fertility, when you think about access, it's growing, I think, exponentially. I think it's part of what Dr. Leondires is talking about. I think as employers continue to understand that covering fertility benefits is good for retention, it's good for recruiting, right? And especially within LGBTQ plus communities, I think access will continue to grow as employers continue to pay or help offset some of the costs. Nothing's covered at 100% typically. And when people feel safe and their friends are talking about it and they feel like they're in a supported place to grow families and others see that, I think you'll continue to see access to care grow.
So focusing in from the LGBTQIA to the T, what are the unique, and maybe they're not unique, I shouldn't always use that phrase unique, but what are the kind of the reproductive and health services issues that are kind of more focused on that community, and what are they dealing with it? And, obviously, can you explain the importance of it? Because it's more, it's different than the path that I would travel on. So kind of, can you espouse on that?
I mean, I think the first thing we have to remember for members of the trans community is, for many of them, just to access medical care is tremendous stress. So for them to think about who they need to be and proactively think about whether they want to be parents, those type of things can't happen sometimes at the same time. So, so finding a safe place to talk about it and learn about it is so important. And what I've seen at our own practice as we've slowly, we've been a fully inclusive practice. I'm the medical director and I'm gay, so it's kind of been an easy thing to educate people. But we've had more and more trans patients feel comfortable coming to us because they talk to each other and they know that we're going to find a place for them to feel safe. But I think that the idea here is that the challenges are significant, because if I see a a 19-year-old who should think about freezing their eggs, but they want to have their top surgery and they can't afford to do both. They want to have their top surgery first. And, for them to freeze their eggs is actually something they can probably wait on, even if they go on hormone therapy, right? For the 19-year-old who wants to go on hormone therapy and stop spermatogenesis, that's a little different. And yeah,
We're not medical field here. So if you want to elaborate on what that means.
For the 19-year-old who was born with testes and wants to transition to a female gender, to use that term, they're better off freezing sperm then. But that's actually a really hard choice for them versus going on a relatively inexpensive therapy to feel comfortable in their body. So it's very hard for young trans people not only to access care, but access the right information. And then after people have transitioned, within reproductive medicine, we have a lot of options. But the message that has been out there for a lot of those people is that they have to either stop their therapy or there are no options if they've already transitioned, hormonally transitioned. That's just not the case. So much of this is just, education and a safe place to talk about it and having providers that are comfortable talking about it. I don't know if I answered your question, though.
No, I think you did. And how would someone go about finding a doctor that meets their needs? What would I'm taking this out of order here, so I hope you didn't study this too in order of how it was. What are the steps to do? Because obviously you say in the Northeast, we are in a bubble, and in the prior session, one of the comments that came up was that if you're seeking a doctor and you do a search in your system, probably within 5 miles, you may find a doctor that meets your needs. But in other states in this country, you might be 60 miles, 75 miles, even more than that. So what's kind of the process that someone needs to go through to find that right specialist?
I can talk, I know Lissa can talk as well. But when you look for a doctor as a member of the community, there's subtle clues. There's everything from their website, maybe it's more than one page or a random rainbow flag somewhere, to picking up the phone and seeing, do they ask immediately, if I called, do they ask immediately who my wife is, right? Getting the forms and seeing how inclusive those forms are. But it is a little bit more work. I also think, depending on your community, spreading the word in the community that you want to be a parent, and usually people pop up, or going to the local LGBTQ center and say, where do people access care? Where's a safe place for us? And those are community networks, and we know who is willing to take care of us. So I think, it's going to be a few things that you need to collect. I always say to be a parent in the LGBTQ community requires first, a lot of research, then intention, then unfortunately resources. That includes money to get you to where you want to be. And it's about a 2-year pathway for most people versus, 50% of pregnancies in the straight community are accidental. They just happen, right? So it's a lot of planning, and with that planning, there's actually a lot of opportunity for success. But it's homework.
Another off-page question. Are you finding those metrics to also hold true for the Black and Brown community, or is it mainly more color bias, as many things can tend to be?
Those things do hold in place for Black and Brown community, but that's another community, though, that doesn't feel safe going to the doctor. In our practice, we've tried very hard to kind of enter that community, and it's been very difficult. And one of the ways that we are doing better now is we have more providers. And we know, and this was mentioned in Classroom A earlier, that we know that there are certain communities that really want to see someone that they can identify to feel safe with. So, but it is a challenge. I think that it's something that we in medicine have to do better at.
Yeah, I think I totally agree. I think word of mouth is really important, talking within your community. I think you talked about members of LGBTQ plus communities more likely are using their own networks and talking about it. I think that's important. When you talk about Black and Brown communities, specifically straight, so talking a little bit separately, they tend to be less likely. There's that research study, I think out of Michigan a few years ago, where they tend to be less likely to disclose to their support communities and so less likely to get support. But I think word of mouth is really important. There are also really good resources out there like Men Having Babies, Gay Parents to Be, and others where you can find lists of clinics that are affirming, which I think is really important.
So Family Equality Council also has a list of providers. And I think you guys have a list of providers.
We do, Yep.
And obviously, depending on your transition that you're going through, what are some of the options for pregnancy options for transgender, whether you're assigned male at birth or female at birth? What are the kind of, because obviously the discussion is different for both.
Right. So I think if you're somebody was assigned female at birth and have not transitioned and know that you want to be a parent, in a matter of 3 to 6 weeks, you could complete an egg cryopreservation cycle. And ostensibly at that point in time, you're probably going to be less than 35 and likely achieve at least 10, if not 20 plus eggs frozen. And then you're those eggs are good for years upon years upon years upon years, right? If you're assigned female at birth and you have transitioned, one of the things that I see that my patients have to process is, do they want to be pregnant, right? And it is perfectly okay for them to be pregnant, right? So, but that's something that has to be personal, and that's something you're going to work with a therapist through and so on. But can you be a biological parent? Can we access your egg pool if you've already transitioned and been on gender-affirming hormone therapy? The answer is yes, right? Depends on the provider. Some providers are going to ask you to come off of medicines for a period of time, which that can be very hard for people and lead to some gender dysphoria. For us, at our practice, based on the literature now, we don't require that, or it's a very short course. And then just like any other, as Lissa mentioned, there's nothing necessarily gendered about fertility care. So just like anybody else who's going through an ovarian hyperstimulation cycle, you're going to take fertility medicines. Instead of just 1 egg growing per month, we're going to go for somewhere between 15 to 20 eggs in a particular month. We're going to retrieve those eggs at a procedure. And those eggs, depending on who your partner is, could be fertilized with your partner's sperm, if they're a sperm-producing person, or you would access donor sperm. So assigned female at birth is going to be either egg cryopreservation up front and then use those eggs and decide who's going to carry the baby, or continue your gender-affirming hormone therapy, make embryos with a partner or a sperm source if you want to be a biological parent, and then decide if you're going to be pregnant, or you can think about an adoption pathway. Obviously, if you're assigned female at birth and you have a sperm-producing partner, you can actually achieve pregnancy, meaning that you can have traditional, penetrative intercourse. Am I allowed to say that here?
Too late now, doctor.
You can cut that. You can have intercourse and just make sure you're working with a doctor that you've changed your hormone medication to make sure it's safe for the baby to be, right? So assigned female at birth have a lot of options. If you're assigned male at birth, obviously there's not an option right now for you to achieve pregnancy. There are some talk in the future about uterine transplantation for those people, which is pretty cool, right? Mm-hmm. But then we need access, if you want to be a biological parent, to sperm. And the sperm producing axis, the testes, are actually a little less resilient than the ovarian axis, maybe because of their location, maybe because of the design of the system. So there may be some of those people who, even if they stop their medication, they're still not making enough sperm for us to collect and use for an insemination. So in this case here, they would end up having to stop their medication and then have a sperm retrieval procedure, which can relatively easily be done. And then that sperm can either be used in the IVF laboratory, or it could be, if they resume to have a good sperm volume and so on that potentially could be used for insemination if they have a partner that was born with a uterus. So, assigned male at birth, the biggest recommendation we can do is to cryopreserve sperm prior to transitioning, and that's usually going to be the best way to do it. And this goes along the same pathway as if somebody who is a cisgender young man gets cancer, we're going to try to freeze their sperm beforehand. So there's a lot of parallels, as you were talking about, that just don't apply to the community. So, in Connecticut right now, I'm really happy to say they just passed a law that basically said that, any gonadotropic therapy for cancer patients should be covered by insurance. And the next step is to get those type of things for young people who apply, feel like they want to transition, to get them also covered by insurance to either freeze sperm or freeze eggs. And at Progeny, that's something that you guys support as well for children of your clients.
Yeah, I'll also add that. So for speaking about fertility preservation, freezing eggs and sperm, Dr. Leondires talked about freezing eggs is about a 2-week process. It's fairly expensive if you don't have coverage through Progeny or elsewhere. Freezing sperm is a 5-minute, maybe depending, process, and much less expensive. So freezing sperm is less costly and less intensive versus freezing eggs, which is much more costly and more of a time commitment.
Yeah.
And then you store that tissue annually, which can be fairly expensive, $300 a year.
Freezing sperm, I'm sorry to interrupt, but freezing sperm, if you're in the process of transitioning or if you've already transitioned, can actually be very difficult though.
It's true.
And very challenging for people. And sometimes they need a reproductive urologist to help them kind of get through that process.
So, the person has, dealt with the transition, they dealt with the various 3 prongs of resources to go through this. Now they're thinking about family planning. All of that can obviously have a mental health factor and a mental health, a negative effect on mental health. So, Lissa, kind of wanted you to kind of speak on that component of it and kind of what resources are there for people going to contemplate going through the reproductive process and kind of what mental health support they can find and out there.
Yeah, great question. I am biased because I am a trained therapist, so I always recommend therapy is a good place to start, whether that's individuals, couples. Dr. Leondires mentioned the LGBTQ community center. Most cities and probably towns have similar, and there are often support groups, some specific to family building. And so I think talking is really good. If you're partnered, talking to your partner is always a good thing. Over communicating, I think, is generally good. Talking to trusted friends and family members. I used to say to my people when I would talk to them, you can disclose, but you can't undisclose. And so if a person is going to continually ask questions that may bother you, maybe that's not the person you disclose your information to. But that obviously is up to everyone individually. And so you talking to a professional person, a therapist, I think to the extent that can be accessed is always a good idea. Again, finding someone who's affirming and understands sort of the family building process is good. Finding support groups, that's another way to identify providers in terms of doctors. And being on the same page with your partner is important. If you're not partnered, leaning on your normal support system of people, siblings or friends, whatever that looks like for you, to talk through. Like, it's a really big decision and it's costly and it's time intensive and it's very stressful, can be quite disruptive. So having that support in place, I think, is really important.
Well, even before you have the support, are there any, any keys or, for example, like, we're all concerning and empathetic colleagues of people.
Yeah.
Like, are there signs that I could look for to say that someone needs support, maybe offer support? Or the reverse, it's very easy to say, speak to your siblings, but maybe you don't even know how to begin this conversation with a sibling. So can you speak on both sides? As, maybe someone who's not part of the actual community, but wants to help their family member or coworker, and then also someone who's in the community that may not even know how to begin that discussion.
Yeah, so like as an ally, someone not in the community, for me, because of what I do, everyone in the world, people I don't even know, come to me and ask for advice around fertility. So I'm trying to think like how would one approach that conversation. I think if I know my friends, a good example is a friend of mine happens to be cisgender male and is gay, and his friend, cisgender female friend, asked him to be a sperm donor for him. And so he came to me like, what does that mean? We would want to parent together, not be romantic partnerships, but friends and co-parent. And so just talked through sort of what that would look like, things to consider, right? Things to ask. I think it's important to be available for just people in your life in general, whether that's colleagues or friends, be a safe place to the extent that anything is a safe place. If you are within the community and don't sort of know how to start that conversation, I think that's where support groups could be helpful. I think that's where a therapist maybe could be helpful. Any person where you feel comfortable disclosing other very private and really personal parts of your life would be a good person to start with. If you can talk to them about your transition as an example, then talking to them about family building may be natural. I think it's all about picking your people to the extent you're lucky enough to have those in your life.
A question that came to me, and I know you probably want to jump in on this, but something I didn't think to ask earlier, because it was a factor in our prior panel. How many states, or maybe it's all of them, currently allow trans reproductive procedures? Like, or is there any type of law against that? Is it available in all 50 states? You're smiling. So
I'll start and I'll let you jump in. So technically, well, first of all, not all 50 states have IVF services. Alaska and I think West Virginia do not. They happen to be states where there's just a dearth of fertility treatment in general.
For all communities?
For all communities,
Okay.
for anyone. I think it's just those two, might be one other. But outside of that gap, every state that offers fertility treatment, theoretically, that would include trans populations. Now, I know from what I know, and this is certainly not true of Dr. Leondires' practice, and it wouldn't be true of most, I think, in obvious sort of cities and hubs. I know in some parts of the country that treatment would not be affirming. That treatment, the doctors would probably not be a safe place for all communities and populations. I think that's probably fair. And so, yes, it is available. I don't know how safe people would be accessing care. I won't blast a state, but
I think
we're all thinking of those
you
states.
can't make the fertility care for the trans community illegal because it's the same fertility care we do for everybody else.
Yeah.
Right? And I'm dovetailing
some
on.
may try, though. Yeah.
Some may try, absolutely.
Sure.
Absolutely. For anybody as part of the community, you need, a fertility center to help you, or at least you need a trained therapist to help you. But I like to stress, you're not getting therapy, you're getting psychoeducational counseling on how to talk to your family members. You're trying to how to choose a donor, if you need a surrogate, how to talk to your surrogate, how to talk to each other, how to talk to your child, right? You also need a reproductive attorney to protect your parental rights when this child is born. So it literally does take a village for members of our community to be parents. And I think that finding out where to get help can be just a simple conversation with somebody you trust to say, like, I think I want to be a parent. And oftentimes they might know somebody, or at least you've let that come out. And then if they're truly somebody who's supportive of you, they're going to go do their own research and so on. And on the other side, for me, it's always fascinating to me that I present, right, as a cisgender white male, and I can hide whether I'm straight or gay, right? But when I basically fully identify with who I am, then the questions start coming. So I think that if you can, everybody here obviously is here because they're interested. But if you can show your interest, then it makes it a comfortable place to talk about being a parent. And I've said for years, being a parent has nothing to do with your sexual identity.
No, I agree. It's often in people's minds. So to drill down on that a bit, if some people may have transitioned while they were with a current employer, so they've gone through that experience with their workforce. Some people may have transitioned prior to joining. But either way, to then say to your employer, I want to now have a child, and this, this can be, as I said, either way, whether this person has known you transition or not. What are some of the things that you would recommend in those discussions? And one of the things you've seen has come up as issues or topics in that discussion with your manager or with your company as far as reproductive rights as it focuses on that community?
Well, for me, they're seeking me out as a provider by that point in time, so I've never
had the work side of it. Maybe it's more of a positive question. Yeah.
I would say, you can always start by checking your HR intranet and find out if your company offers fertility benefits, and going straight to the benefits is a good place to start. So if they have progeny in place, you can call and not even have to speak to your employer directly. Call progeny and ask lots and lots of questions, and it's what we do all day. And so there'll be someone on the other end of the phone who answers nearly immediately and can answer literally any question that you have, around fertility.
But even if you got called Blue Cross Blue Shield.
Yeah, yes.
Do I have fertility
Do
benefit?
I have, exactly,
Do
yes.
you cover insemination?
Yes.
Do you
Yes.
cover IVF?
What are my options?
Those are
What
all
are my,
standard questions.
Yep. I think depending on your employer is whether or not, I don't know that most people disclose to their manager. Again, as progeny employees, we also have the progeny benefit, and this is what we do. So I know everyone on my team who is working with a fertility doctor. It's just what we do. But I think outside of that very biased group, I don't think most people go to their manager and say, I'm embarking on family building. They're maybe afraid that opportunities may pass them, and that may be true in some cases. There are in a lot of employers ERGs, right? There's often pride groups, and so that might be a good place to start having those conversations. And then directly to your employer, there's often not a lot you really have to talk about until you're expecting, I think, unless they don't offer fertility benefit, in which case it may make sense to advocate for one.
Well, one item that came up in the prior panel was it was a cisgender lesbian couple, and she had asked her new employer about benefits, but you probably know what I'm talking about. But she didn't ask, but the benefits they were available were only if she and her wife were both infertile, which was not the case. So while the employer said, yes, we have fertility benefits, she didn't drill down.
She didn't have progeny.
Yeah, she didn't. Well, exactly. She didn't have progeny. So I think even when you're asking a question, you kind of have to know. I was thinking
that when Dr. Leondires was speaking. So you call and say, do you cover IUI, IVF, and what are the requirements to access those benefits? So oftentimes in a traditional insurance coverage, you have to prove infertility in order to access benefits, and you prove infertility typically by 6 to 12 months of heterosexual sex that fails, or by paying for 6 to 12 fertility treatments that fail, and that's how you prove your infertility. At Progeny, that's not the way it works. We don't have that requirement because it does, I would say, maybe discriminate against, exclude certain people.
So the WHO, World Health Organization, many years ago basically said that you can be a member of the LGBTQ plus community and you meet the definition of infertility. You can be a single person and meet the definition of infertility. It was literally just this past October that our parent organization, or my parent organization, the American Society for Reproductive Medicine, came out and said that with a fully inclusive definition of infertility, because the insurance companies have always used the ASRM definition to say, well, we don't have to cover you because you don't have infertility by this definition. So the veil has been lifted. I'm not sure if I used that correctly, but the shroud has been lifted, and now there's going to be pressure on those insurance companies to defend why. This is also something I've been saying for years. If you're sitting next to your colleague and they have an opposite sex partner and they have a full palette of fertility services in IVF, and you have the same job they have, you're paying the same benefits they have, and you just happen to have a same-sex partner or no partner, and you don't have access to the same benefit, that's not fair, right? And you've been discriminated against because of who you are, and you can't change that, right? And that it was always kind of held back by the insurance companies if you don't meet that definition. And if you're a same-sex cisgender female couple, you'd have to pay $30,000 probably to do 3 to 6 inseminations to prove that you are infertile, right? And but now that's hopefully going to change. And there are some, there are some opportunities now for things to change. And Illinois, as a state, the state mandate, it now covers members of the LGBTQ plus community to pursue fertility care. Connecticut just passed this year. It's going to take a couple years to come in. So, New York is considering it right now. So that being said, everything has started as this small snowball that we want to get bigger and bigger. But I think that that you have to, the questions to ask, the last question is, and what if I have a same-sex partner, right?
But bringing the focus back to the trans community, what advice would you both have on someone beginning that journey? Because I mean, if you're going through your transition, you may not be thinking all the way down the line to should I have frozen eggs or should I have frozen sperm? And the costs involved in these things can be quite astronomical outside of whatever your insurance benefit package is. So kind of like if you're beginning that not necessarily the transitioning journey, but thinking about the reproductive life you may have, what are the first things you would recommend?
I think that if you can be a parent, if you're a member of the trans community, you can be a parent. And yes, it's going to require a little bit more homework. Make sure you're going to the right place that has experience. Maybe a change in your medication profile, right? Maybe not. And it's doable, right? And that, knowing that that's the case is something that I think a lot of people weren't always aware of as well.
We get not infrequently calls from parents whose child is transitioning, and the parents say to us at Progeny, like, I know that this may affect my child's future fertility, potentially, or delay it maybe. And so what should we think about now? And so if you're pre-transition, thinking about fertility preservation, as we've talked about, is important. If you're in or post-transition, I think understanding options, maybe starting with your provider, not even necessarily fertility provider, but starting with the provider you feel most comfortable with to understand what options are. And then I always recommend having a conversation with a doctor like Dr. Leondires. Talking isn't doing, right? You can sit down with him, and I don't know how long your initial consults are, 30 minutes, 45 minutes. Bring your questions and just understand what options are and what each of those options entail. And then I think talk to your community about what all of that means.
A lot of times where you're getting your gender-affirming hormone therapy is going to be a place to start as well. The other part of the story is I always find it's better to have 2 sets of ears, because sometimes when it's personal, you don't hear as well. So if you can bring somebody with you that you can bounce things off of later, that's really helpful.
And bring questions to write them down. I always find is really helpful.
You talked about resources. Can you go over kind of the average cost of what it would take to become a parent, to build a family?
Yeah.
So depends on your pathway, right? So if we're going to pursue insemination with, let's say, donated sperm, each cycle is going to be somewhere around $1,500 to $3,000, right?
I'm sorry, say that again?
$1,500 to $3,000 for an IUI.
I think you said something else. Okay.
Plus,
right,
the donor sperm is about $1,000 a vial.
Yeah. So it's kind of like you're budgeting, like each try, let's just make it $5,000, right? An IVF cycle out of pocket, and you know more about this than I do, what the general is. I know what ours is about.
Yeah, so an IVF cycle is much more expensive because you're talking about very expensive medications. If you're using autologous eggs, so have a person who's using their own eggs, oocytes, then an IVF cycle is probably in the neighborhood of $15,000 to $20,000. There are a lot of things you can add on to that, and so the costs can climb. If you have no coverage, right? We're talking about paying totally out of pocket. I'll say comparing the two seems drastic, and it is. The IUI, your success rate with each one is what, 12, 15%? Yep. IVF at a clinic like Dr. Leondires is closer to 50, 60%. And so there's a big difference there, right, in terms of outcome. IVF also includes fertility preservation often because you usually make more embryos than you need in one go. And so it may be more cost beneficial, and these are things to talk about.
If you add a donor on top of
If
that,
you had an egg donor, which is where I was going next, thank you, you're probably doubling that IVF cost. So it's more like $40,000, $50,000 for a donor cycle. That's an egg donor. And surrogacy, just using a gestational carrier. So if you need a uterus, that is probably in the neighborhood of $100,000 and up. There are ways to cheapen it. There are ways to make it a little less expensive, but if you're two people who make sperm and you need eggs and uterus, then your all-in cost is probably in the neighborhood of $150,000. If you're two people who make eggs, your all-in cost is probably closer to $20,000, $25,000. If you're opposite sex or male assigned male at birth and assigned female at birth, and one of you has a uterus and one of you has eggs, then you're probably talking somewhere between $3,000 and $30,000. Good question.
We hear all the time at Open Finance kind of ranges of fertility benefit. Like, what are, and it's kind of a race to move up.
Yeah.
And
Yeah.
try to make that happen. What's a good number? Like, what numbers do you see? Like, what's the range?
In terms of
an
coverage.
employer coverage, yeah.
Yeah,
Or,
yeah.
like, what do you see?
So,
Without anything, obviously.
yeah. So I'll talk about outside of progeny first, because ours, the way we structure the benefit is a little different. Oftentimes you see dollar maxes, and so you have X dollars to use towards a lifetime. I think anything less than $30,000, you're probably not going to get coverage for even a full journey. Keeping in mind that really no benefit out there covers the gestational carrier. There's usually a separate bucket of money that is what we call post-tax that you can use towards that. So we're really just talking about achieving pregnancy with either the couple or the intended parents or a single person, or creating embryos for that journey. So anything less than $30,000, you're probably not going to get a ton of coverage through that. With progeny, we cover the benefit as episodes of care. And so Dr. Leondires will be very familiar with this. We call them smart cycles. And so the full IVF cycle is covered, the full donor cycle is covered, and it deducts from your lifetime max. So it's a little, I, again, am biased. I think it's a little better in terms of comprehensive coverage. When you have a dollar max, you chip away with really every visit to the doctor. And so you need a high dollar to start with. And what we talked about too is really important, making sure that the benefit you have in place is equitable, that's inclusive, that you don't require that infertility diagnosis to access. Otherwise, much of your trans population, gay, lesbian, will be excluded from coverage.
I mean, and we always have to kind of just understand that compensation of the people that help you, the sperm source or the egg source, or the sperm donor, the egg donor,
That's right.
and the surrogate are usually completely
Right.
out of any insurance benefit. And that adds up to, $150,000 to $200,000 for if you're gonna do, a surrogate plus an IVF cycle plus an egg donor. That's kind of the top level. And a lot of people in the trans community, they do not need that much support because there's usually, somebody in that relationship, if it's a couple with a uterus, but they might not always want to be pregnant. So that's where it really the question lies. Because the largest expense in this whole thing is the person carrying the baby.
Yeah.
For 9 months, and a couple months beforehand and a couple months after to prepare and recover.
Yeah. Eggs and uteri are very expensive, as it turns out.
Does that answer your question?
Yeah, I think so. I mean, I think 75 is the new number.
The number we've been hearing since as of last week is $75,000. We heard that last week at a meeting. We heard it again today.
Good.
But as a
Are there-
lifetime.
Yeah.
So if you wanted to.
Oh, that's a lifetime number,
Yeah.
not an annual number. Oh, okay.
Oh, it's always lifetime max. Yeah.
Yeah.
Are there firms out there that are 150?
There are firms out there that are unlimited. Absolutely. Yes. That's
That's where we should go.
That's the yes. That's the small number, but yes, there are firms out there that are unlimited.
The reality. I mean, I've done some employer talks as well. The percentage of people who are going to use this high-level benefit is
Yes.
so small.
Like 1%.
To offer
less.
it is just provides such a feeling of safety and wanting to stay with the company. It's worth it.
Somebody we were with last week made that exact point that, even if you made the benefit 150, you're not talking about, your entire workforce. The benefit is so worth it for the people who get that 150. It's so worth it.
Absolutely.
Well, thank you both. Any more questions? Oh, yeah, please.
I'd love to hear a little bit about some of the things that you can do. Let's say you're for a firm and the policies are pretty well defined, and we're talking about this cost. It's a 150, 200 max for a trans woman like myself. So I'm wondering, what are some things that you recommend kind of in that interim phase where maybe this policy is coming due in a few years, that's going to reshape some of that? What are some things that you can do to bring that down, whether that's international or some programs that you all have access to or recommendations?
I'm going to start and I'll jump
I can certainly start it. I think that recognizing that there's defined stopping points. So, there's have your genetics evaluation done, assess your sperm count or your ovarian reserve, and decide. And if it's a situation that you can cryopreserve anything up front, get that done. And that's just done, and that's a bucket that you spent, this year, right? If you're somebody who's going to need a surrogate, well, the matching time for a surrogate approaches a year, right? And you can pay a surrogacy agency to do an intake and get on their list so you could chunk up their list. But just because you're at the top of their list doesn't mean you need to go. It just means you're at the top of their list. So you can put that money down, get your interview, get there, and then, so if it takes you 3 years to get to an embryo transfer, you've now spread out those costs over those 3 years, or maybe things have changed. So I think having the initial consultation, understanding your genetics, understanding your options, and then, so for people who were born with ovaries, there is a real biological clock. So understanding that, don't wait too long if you were born with ovaries to make your decision, because sometimes, the time has passed for you to have the best outcome. Does that answer your question? Yeah.
I would also, people born with sperm, there's a fertility decline too, but it's not as rapid. I would also add, if there are ways to advocate with your employer to increase or adopt coverage, there's an option there to talk about the importance to you if you feel comfortable. Not everyone does, and that's real. To talk about why this coverage is important in terms of getting it through your employer. There's an option there. And I like what Dr. Leondires said about scaffolding the costs. So have maybe just the visit with a doctor next year, maybe make embryos. That's a stopping point. Talk to surrogacy agencies. You can often do that for very little cost.
Understanding it's a time dependent process. Yeah.
Good question.
Thank you very much.
Thank you, Justice.